in the first month after the PCI is about 2.2%, and in the first year it's about 4 to 12%. So it's a very difficult clinical decision to see which is the right decision for the patient. So the question is, what is the most appropriate anti-arrhythmic, antithrombotic agent to manage atrial fibrillation and the coronary artery disease in the patient with acute coronary syndrome and need to be PCI? And how we balance the ischemia and the bleeding risk in this high-risk population. So we will separate two different, most common use new anticoagulation. This is Xarelto and Pradaxa and Dabigatran in the different group for my today's topic. So let's see the Rivaroxaban, the Xarelto first. The fact compare the Xarelto to the to the warfarin, we know Xarelto has a lower or non-inferior risk of stroke and systemic embolism. This is from the Rocket AF trial. And Xarelto has a similar rate of major bleeding compared to warfarin. But they have significantly lower rate of intracranial hemorrhage and fetal bleeding compared to warfarin. So this is the benefit for Xarelto to use the patient in AFib than the warfarin. But when you have a patient with ACS and you use the Xarelto with dual antiplatelet, this is the dual antiplatelet treatment, even with the low dose, 10 milligrams a day, this is not the suggestion for a stroke prevention in atrial fibrillation population. So this is very low dose, 5 milligrams a day or 10 milligrams a day. You still increase the population with the bleeding. And Xarelto, but if you use a very low, extremely low Xarelto, 2.5 milligrams twice a day, and combined with aspirin and P2Y12, most are used is Plavix, and they have significantly reduced the deaths from cardiovascular causes, MI, and stroke for the second prevention with the patient with ACS. So Xarelto might be benefit with very low dose routine combined with the dual antiplatelet treatment. So this is the clinical trial to study about the Xarelto in patients with atrial fibrillation in the PCI. This is called the Pioneer AF PCI trial. It's published in December 2016. So it's an open-label, randomized, controlled, multi-center study. And the main idea is they want to see whether the Xarelto group has a reduced rate of bleeding and similar efficacy in prevent cardiovascular event. So they designed for 3 different groups. The one group is a low-dose Xarelto at 50 milligrams daily plus single P2Y12 for 12 months. Majority of people will accept it is the Plavix. Group 2, same thing, very low-dose Xarelto 2.5 milligrams twice a day plus dual antiplatelets for 1 month or 6 months. So after 6 months, and the Xarelto will be changed to 50 milligrams and plus aspirin until 12 months. The third group is a standard therapy for the next couple of medicines. Usually they use warfarin plus P2Y12 and plus aspirin as a standard reference group. First 1, 6, and then same things. After 6 months, warfarin will be plus aspirin till the 12 months. So let's see the study group. It's very small. Basically, it's about not that very large. Each group probably is around 700 populations to involve the study, and totally about near 680 in the patient can be analyzed in the end of the study. So the age, it's very small. The age is average around 70. And the patient, most of the study is a white population. And the other races is very few. The other thing is majority of the P2Y12 they use is a Plavix. And the CHEST score average is the CHEST score, we use it for the stroke risk evaluation. So CHEST score between 2 to 5 with average of 3, probably the most population situation. And in the end of the study, the primary endpoint is combined the major bleeding. So you can see the group 1 is the Xarelto 15 milligram daily, combined the P2, combined the Plavix 75 mg daily, is the less bleeding risk compared to the warfarin with the dual antiplatelet treatment. Probably almost the double the risk of the bleeding. And even you combine the different groups, this is the very low dosage for Xarelto plus dual antiplatelet. Even the low dose Xarelto with dual antiplatelet has less risk bleeding compared to the warfarin with dual antiplatelet. And the major advice event is especially for the cardiovascular event and the in-stent thrombosis event. Looks like the Xarelto group with 15 milligrams a day combined single P2Y12 is a little bit higher than the other groups, but there's no significant difference. So they said, okay, from this point, I think it's probably no inferior than the warfarin plus the dual antiplatelet treatment. So this is a Kaplan-Meier study, and it shows the bleeding risk in the group 3 is more higher than the group 1 and the group 2. But if you combine the end standpoint of the treatment efficacies, include cardiovascular event, thrombosis, stroke, and other things, looks like low dose Xarelto combined dual antiplatelet is better than the single 15 milligram Xarelto combined single Plavix, then better than the warfarin plus 2 antiplatelet treatment. So the conclusion from the PIONEER study is that in participants with atrial fibrillation and PCI and with placed stent, the administration either low dose Xarelto plus a single P2Y12 inhibitor for 12 months, or very low dose Xarelto plus dual antiplatelet for 1, 6, or 12 months, associated with low rate of clinic significant bleeding, then standard therapy with vitamin K antagonist plus dual antiplatelet. So we'll see next. Next, the medicine we talk about is the Pradaxa. So the fact with the Pradaxa compared to the warfarin is there are 2 dosage uses. One is 110 milligram, which used outside the United States and in the other world, and the one we use 150 milligrams. So compare the clinical trial with from the Reddy study, we know that Dabigatran 110 milligrams has the same rate of stroke and system and embolism, but low rate of major bleeding. It makes sense because you low dose. But 150 milligrams, what we use here is you have a lower rate of stroke and systemic embolism and similar rate of major bleeding compared to warfarin. So when you study the subgroup, you will find that Pradaxa has high rate of major GI bleeding. Probably is where the chemicals they build for the medicines has some acid in there, so that might be the reasons. And both doses of Dabigatran has a high rate of myocardial infarction. This is where we see the first slide, and it probably because they suppress thrombin is not enough compared to the factor 10A inhibitor. And both doses of Pradaxa has the low rate of life-threatening bleeding and intracranial bleeding. This is the benefit compared to the warfarin. And the other thing is when you use the Pradaxa, you have to needed a very low pH in the stomach to require enhanced absorption. So if you use anti-acid medicines with the Pradaxa, you might be decrease the anticoagulation effects. So this is the 2017 trials involved the Pradaxa called the radio PCI trials. So this is also an open label randomized controlled multi-center study. So the idea designed for the study is say whether the Dabigatran has a lower risk of bleeding in 14 months and no inferior in prevent thromboembolism event compared to warfarin. And there are three groups, same things, three groups. One group is used 110 milligram twice a day plus single P2Y12, majority is Plavix. Group 2 is the 150 milligram twice a day plus Plavix, and the third group is the standard warfarin plus dual antiplatelet. So in the third group, aspirin was stopped in the first month with the bare metal stent and 3 months after the drug eloting stent. It's a small study. The study is involved probably 2,700 patients, and each group probably close to 970 population in different groups. The same things. The age is around is compared to previously around 71 years old, and the majority is a white population, and 100% people has atrial fibrillation, and majority P2Y12 usage is Plavix. So the endpoint study for this study is the risk of a major bleeding. So compare the group with Dabigatran 110 and warfarin. You will see warfarin almost double the size bleeding risk than the Pradaxa plus single P2Y12. And compare the 150 milligram dosage is the same result. So the major bleeding is more when you use the warfarin with dual antiplatelet. Better use the single Pradaxa and the single P2Y12 agent. But if you see the combine the efficacy endpoint with the thromboembolism, death, and explained revascularization, warfarin is a little bit better than the Pradaxa group. So that means Pradaxa group probably has a more thromboembolism event. But the study showed there is no significant difference. A little bit high, but not significant difference. So this is the Kaplan-Meier study for the endpoint and second efficacy endpoint from the primary. So the triple therapy, you will cause more bleeding, and compared to the thrombosis group, and there is no significant difference. Dual therapy with the Pradaxa may be a little bit high thromboembolism event than the triple therapy with warfarin and the dual antiplatelet. So the conclusion from this study that shows among patients with atrial fibrillation who underwent PCI, the risk of bleeding is lower among those who receive dual therapy with Dabigatran and a single P2Y12 inhibitor than those with triple therapy with warfarin, P2Y12, and plus aspirin. So dual therapy is no inferior than the triple therapy with respect to the risk of thromboembolism events. So let's talk about the last one is the Apixaban is the Adequus we use. The fact for the Adequus we know compared to the warfarin, Adequus reduced the risk of stroke and systolic embolism by 21%. And this is from the AUGUSTUS study. The major driven is by decrease the hemorrhagic stroke. It's not the ischemic stroke. And Adequus reduced the major bleeding by 31 and the death rate by 11% compared to the warfarin. Reduce the GI bleeding compared to the Pradaxa, probably increase the GI bleeding. But there are some scenarios from the Apixaban 2 study showed if you use Aliquot 5 milligrams twice a day as a routine compared to dual antiplatelet or even single aspirin versus using Aliquot alone. In a patient with acute coronary syndrome, you significantly increase the risk of bleeding if you use dual antiplatelet with Aliquot or single aspirin with Aliquot. And without the efficacy to decrease the incidence of ischemic event. So this is the current last year's trials called AUGUSTUS trials, compare the Perdex treatment after acute coronary syndrome or PCI in the atrial fibrillation population. So this is also a prospective multicenter 2x2 factors randomized large studies. The hypothesis is for the study is one, Aliquot at least non-inferior and possible superior to warfarin in regard to major and clinic event, major bleeding or clinic relevant non-major event in patient with AFib and acute coronary syndrome or after PPI. The second hypothesis is a single therapy of Aliquot with single P2Y12 would be superior than the P2Y12 plus aspirin in regard to major or clinically relevant non-major bleeding in patients with AFib and ACS. So same things like the previous two clinical trials, they have three groups. So one is the Apixaban group, 5 milligrams twice a day. This is the routine we use for stroke prevention in AFib patient, plus single P2Y12, compare warfarin to P2Y12. This is open label. And group 2 is aspirin plus single P2Y12 compared to placebo is a double blind with the P2Y12. So this is a crossover study to see the different analysis, different factors. Major things you want to answer whether added aspirin is better for the patient in the clinic result. So this is 4,000, much larger. It's a 4,600 patient involved and separated to 3,200 in different group and study. This is the study compared the Aliquot to the warfarin, and this is the try to answer the question of aspirin with the placebo. Same things. The group population age is around 70, and the majority is white people, and this is also the high-risk population group. The other things is their chest score is average is around 4, so it's high risk for stroke, and the bleeding risk has-bled score is around 3, so it also has a high risk bleeding. Majority people again use the P2Y12 is the Plavix. So the primary safety and secondary efficacy outcome, you will see the bleeding risk is much higher when you compare the warfarin to the Aliquot. Aliquot is less than the warfarin. So this is compared same like Xarelto and Dabigatran. And with antiplatelet, you added aspirin, it will be high risk of bleeding than you give the placebo. So this also makes sense. So this is the combination Kaplan-Meier curve of primary outcome and the major clinically relevant major bleedings. You will see the first one is red one is the vitamin K group, and the green one or blue one is the Aliquot. So this is the major bleeding risk compared to these two agents. This is the compare aspirin and the placebo. So this is a little bit small color. It's a difficult differentiation. The top one is the warfarin plus aspirin, and the second one will be Aliquot plus aspirin. The third one is warfarin plus placebo, and the most safe one is the Aliquot plus placebo. So the bleeding risk looks like if you added aspirin, you have more risk than usual. If you use warfarin, then the Aliquot, you're bleeding more. So this is the combined death and hospitalization curve. And the major thing they want to say that combined the vitamin K antagonist warfarin is a little bit more death and hospitalization than the using Eliquis alone. And if you added aspirin and placebo has no significant difference, but if you added aspirin in each group, and it looks like you have a more number of deaths and hospitalization, major driven by the hospitalization, not the clinical death. So this is the combination with the secondary standpoint. This is very small amount. So the conclusion from the AUGUSTUS trial is answer two questions. So if you use P2Y212 plus Eliquis compared to warfarin, you will need lower incidence of bleeding and hospitalization. The ischemia event was similar. And when you use P2Y12 with aspirin compared to the placebo, the aspirin group will be increased high bleeding risk. So avoid aspirin result a 47 lower risk of bleeding. And they have an equal death, hospitalization, and ischemic event compared placebo and aspirin. So there didn't show benefit with the aspirin added on the anticoagulation with this group patient population. And a high number of coronary ischemia events without aspirin, that is also makes sense because you have a dual antiplatelets with this group. So probably instant stenosis is lower with aspirin, but the downside is you have more bleeding, more hospitalization, and the death rate. So the conclusion from AUGUSTUS trial was about the Eliquis is that in the patient with atrial fibrillation and recent acute pulmonary syndrome,